if patient is taking any medicine since a long time, so some medicines
Dr. Deepak, unmute yourself.
वीडियो पॉज हुआ है उनका.
Sir, his internet is stuck.
What has stopped?
His internet.
Internet. Okay. हाँ. He's joining again.
All right, sir.
Yes, Anil, what has happened?
आम्ही त्यांना फोन करतोय सर फक्त. He's joining.
Okay.
This is what happens with web platforms. Sometimes the network goes.
What did he say, Anil?
He said he's joining within 1 minute. Yeah, he is there.
Okay.
Welcome back. Welcome back.
Unmute karo, unmute.
Okay.
Yeah. You can share the screen again.
हुआ क्या शेयर?
हाँ, उसको नीचे करो. हाँ, right. नीचे का है शायद ना, इम्पोर्टेंट.
हुआ?
ये है ना? हाँ, right. Same presentation or?
Yeah, it is same.
Yeah. So, yeah. Yes.
So the 10th question is, are you taking any medicine since long time? So these are the ototoxic drugs if patient is taking since long time, like quinine, nicotine, caffeine, salicylates, streptomycin, gentamicin, contraceptives, psychiatric and muscle relaxant. So are you able to stand without support or not? In central vertigo, needs support to stand, patient needs, and in peripheral vertigo, usually able to stand and walk without support. So in central vertigo, onset is gradual except vascular ischemia, and it is a persistent. Whereas in peripheral vertigo, the onset is acute. Duration is longer in central vertigo and shorter in peripheral vertigo. It triggers by postural changes, is rare in central vertigo and common in peripheral vertigo. Nausea, vomiting is a moderate in central vertigo and severe in peripheral vertigo. Auditory symptoms is uncommon and common. Rotatory symptoms is uncommon in central vertigo and common in peripheral vertigo. And imbalance is severe in central vertigo and mild in peripheral vertigo. So any diplopia or dysarthria or facial numbness. So these are all warning alarms. I mean, these patients, basically, most of them have CNS causes, like persistent vertigo with increased severity day by day, ataxia, persistent nausea, vomiting, severe headache, diplopia, vision loss, slurred speeches. I mean, these are the patients managed by neurologist. Most of them have CNS lesions. Now, so history according to disease. Like in a BPPV, that is benign paroxysmal positional vertigo. So in this otolith, which is present in saccule and utricle, it degenerates and settles in semicircular canal, mostly in a posterior canal because of its anatomical position. So these semicircular canals are sensor of rotations, but because otolith goes into the canal, it becomes sensitive to gravity when patient turns in bed. So the patient gives the history of sudden onset and during supine position or from supine to sitting position, patient gets a dizziness. The latent period of onset of vertigo is 1 to 30 seconds. It lasts for few seconds. It is rotatory in nature, the vertigo, and not associated with hearing loss, tinnitus, earache, and fullness in ear. This BPPV, the pharmacotherapy do not have any role in BPPV, and one has to do liberatory maneuver. Meniere's disease. This is a endolymphatic system is distended in Meniere's disease. The patient gives 2 or more past attack history, so that is episodic, associated always with tinnitus, ear fullness, and decreased hearing. That is, this is a triad which diagnose the Meniere's disease. Usually with nausea and vomiting, last for few minutes to hours. It is rotatory in nature, but not related to any particular position of the body. Vestibular neuronitis is an inflammation of vestibular nerve secondary to viral infection. Most patients have history of rhinitis or LRTI. The sudden onset, severe vertigo, nausea, vomiting, last for few days to month. Unsteadiness remains few days after giddiness gone. No hearing loss. Labyrinthitis is an inflammation of an inner ear secondary to infection, usually associated with hearing loss and tinnitus. History of ear discharge, fever, and ear pain. Patient gives this history. This vestibular migraine. So 40% of a migraine patient have a vertigo. Vertigo may or may not be associated with headache. There is always aura, headache, photophobia, phonophobia. Vertigo may be or may not be associated with head movements. Tinnitus may be present because of inner ear vessel spasm. Repeated attacks of vertigo. There is a family history of migraine. Vestibulopathy is an age-related disturbance of a balance system. Age-related hearing loss also will be there. No rotatory vertigo. Sensation of imbalance, that is worsens in dark and uneven surface. Movement induced blurred vision. And no symptoms while lying down or sitting. Psychological vertigo, like patient has a psychiatric disease, persistent for months or years. Usually wake up well, but symptoms worsens as day passes. Complaints are vague, numerous, and out of proportions to findings. Family history of stress and anxiety. And in pediatric patient, complain most of the time while going to school. Phobic postural vertigo is a consequences of vestibular disorder. I mean, previously patient had some attack of BPPV or any other disease, and then patient develops this. So it is a fluctuating in nature, difficult to walk in darkness, afraid to look right and left while crossing the road. Dizziness increases in crowded place, empty room, department store. Fear of heights, patient may have obsessive personality. So most common diagnosis in OPD is BPPV and vestibular migraine. These are the two most common symptoms or a diagnosis we get. Then Meniere's disease, vestibulopathy, vestibular neuronitis, labyrinthitis, psychological vertigo, phobic postural vertigo, and central vertigo. Now, management of acute vertigo. First, we need to differentiate between peripheral and central vertigo before starting treatment. Otherwise, it will suppress the symptom and one may miss underlying pathology. So these are the drugs which are commonly used for a vertigo, like cinarizine, dimenhydrinate, meclizine. This suppress vestibular and organ receptors, inhibit activation of central cholinergic pathways. Prochlorperazine suppress action of central vestibular nuclei and pathways. Beta-histine, it improves the blood flow to labyrinth and brainstem. Acetazolamide decreases intralabyrinthine fluid pressures, mainly given in Meniere's disease, and corticosteroids. So given in viral infection like vestibular neuronitis and in autoimmune ear disease. Now, cinarizine in dose of 25 to 75 milligram 3 times a day is one of the most commonly prescribed drug for vertigo in our country. It has a labyrinthine sedative effect. It reduces plasma viscosity, which enhances microcirculation in inner ear. It stabilizes vascular endothelium, which in turn promotes transport of nutrients to neural tissue. It inhibits the entry of calcium ions into RBCs, which makes RBCs more foldable. So they can easily pass through narrow arterioles of inner ear and cerebral tissue. Cinarizine doesn't have risk of extrapyramidal reactions like prochlorperazine. It can be given in peptic ulcer and bronchial asthma, unlike beta-histine. Dimenhydrinate in dose of a 50 milligram 3 times a day given in acute vertigo with accompanying vegetative symptoms like nausea, vomiting, and sweating. Dimenhydrinate inhibits vestibular input into vegetative regulation center in medulla. Anticholinergic and antihistaminic properties, which exerts its anti-vertigo effect by inhibiting muscarinic receptors present in synapses of central vestibular pathways in connection of vestibular nuclei. Dimenhydrinate does not have risk of extrapyramidal reactions like prochlorperazine. Now, when these two drugs are given in combinations, acts synergetically and which allows lower doses than when cinnarizine and dimenhydrinate are used as a monotherapy, and the improved clinical efficacy and fewer tablets that have to be taken will also encourage better compliance with the therapy. Contraindication of this combination is severe renal and hepatic impairment and should be used with caution in patient with condition like raised intraocular pressure, pyloroduodenal obstruction, prostatic hypertrophy, hypertension, hyperthyroidism, or severe coronary heart disease. Thank you.
Thank you very much, Dr. Deepak Desai. There's only, I think there's one question. What is the role of cervical spine in vertigo? Because so many patients suffer from vertigo after muscle spasm in the neck, especially after laptop or even after some desk work.
So basically, etiopathogenesis of this is not understood. But in cervical spondylosis, whenever patient turns his head to right or left, there may be compressions of a vertebro-basilar artery, and that reduces the circulations, to the brainstem area and near the vestibular nuclei area, can lead to vertigo in this. But I have not found these patients too much in my clinic. Most of them are BPPV and manias or a migraine vertigo.
One more question is from Dr. Kalpesh Gavan, which is the best drug for acute vertigo?
Acute vertigo, first of all, in BPPV, there is no role of any medicine. But in vestibular neuronitis or in other disease like manias and all that, the cinnarizine works better. Cinnarizine and dimenhydrinate works better. With the beta-histine, we give in manias disease. It has a good role. We give at least for a month.
Okay. As per your experience, does prochlorperazine causes extrapyramidal reaction very often?
Not very often, but yeah, there is some percentage of patient comes with the extrapyramidal symptoms.
Okay. One very different question. सब लोग बोलते हैं you are a singer, झूम बराबर है झूम शराबी. So how does alcohol causes a rotational sensation?
Yeah, so that's very good questions. Now, see, alcohol, whenever it's taken, so it reaches inner ear. And alcohol is always lighter than endolymph present in the inner ear. But we have receptors in a semicircular canals known as the cupula. So this cupula receives alcohol goes very rapidly in the cupula because it has a very good blood supply. And compared to endolymph, I mean, in endolymph, it will take a little longer time, but it will reach in cupula faster. So this produces, buoyancy in the cupular region. Okay. And so that's why whenever we turn our head, so this, add up, this signal add up and we get severe rotational sensation.
Yeah. Thank you very much, Deepak, for this elaborative reason for this Jhumna. Lastly, I'll just tell you to, I mean, in short, just tell me how to manage BPPV. BPPV.
So BPPV is basically, can I share the screen? Okay. Yeah.
Yeah. Piyush?
Yeah. So here you can see this is cochlea. This is sacule and utricle. So in sacule and utricle, we have a macula, and this macula has this otoconia. That is the calcium carbonate crystals, which is for a linear movement. You know, it basically senses linear movement. Suppose we are traveling in car, so this senses it, or either we are going in lift. So it is either vertical or a horizontal. So this, if there is some head
Excuse
injury,
me, sir.
or
Uh,
if
Sir, the
the
PPT is not visible, sir.
picture is not visible,
No, sir.
अच्छा, I need to share screen again.
तुम्हारा स्क्रीन शेयर हुआ ही नहीं.
अच्छा, there is no screen share. 1 minute, I'll share the screen. Now is it visible?
Yeah. Now it is.
So this is cochlea, sacule and utricle. So in sacule and utricle, this is macula, and this macula, over macula, there is this otoconia, which is a calcium carbonate crystals. And these crystals, gives a sensation, basically senses the vertical or a horizontal sensation. So whether we are traveling in car or we are in lift, this senses. But in case of head injury or some whiplash injury, so this dislodges from here, and 85 to 90% of the time it goes into the posterior semicircular canal. So now what happens, because these crystals are heavy, after some times it starts moving inside the posterior semicircular canal, and it rotates the endolymph and basically stimulates this cupula of the semicircular canal. So this basically are for angular movement, but then it becomes now sensitive to gravity. So that is a BPPV. Now, if we come to know that which side is involved and which canal is involved, then we can treat this BPPV in clinic itself. So for that, there is some test we need to do to find out which canals are involved, which side, right or left. For that, there is one test known as the Dix-Hallpike test. So this is a Dix-Hallpike test. Can you see video? Are
No,
you
sir.
able
To
to?
play the video, you'll have to share the screen again.
I have to search screen again. Okay.
Okay, it's visible now. Please, we can
Visible?
start again. Yes.
Okay. So here you make patient sit and turn the patient head to 45 degree. After turning the 45 degree on the right side, make patient lie down and head should be hang 20 degree below the horizontal surface. So this would make a particle to rotate towards the gravity, which is more dependent side, and will induce a vertigo in patient, towards the undermost ear. And this vertigo would be torsional upbeating vertigo. So if this is happening on the right side, it means the right posterior canal is involved. Or if on the left side it happens, it means the left posterior canal is involved. So this is the torsional upbeating nystagmus, like right upbeating. This is how the nystagmus happens. So this is, in this case, if the right posterior canal is involved. In left side, if it is happening, that is undermost ear. Here you can see left torsional upbeating nystagmus is happening, and patient is also giving history of vertigo. So we come to know that which side of the posterior canal is involved. However, Dix-Holpike test and superior canal also, but in superior canal, it would be torsional downbeating nystagmus. So if it is a right torsional downbeating nystagmus, it is a right side superior canal. Left torsional downbeating, it is a left superior canal. So how do we treat this? So to treat this, for a posterior canal, we...
Can you be a little brief because we are running short of time?
Okay. So this is a postural Epley's maneuver. So suppose here we are considering it is a right postural canal involved. Then you make patient lie down and turn the head 45 degree, 30 degree down. And this would, take the otolith towards the most dependent side, gravity, and that would give again, as I said, the upward torsional nystagmus. Now you turn the patient total 90 degrees, so on left hand side. So again, the otolith would enter. Now you turn the patient again 90 degree facing nose down. So once the patient is nose is facing down, it would enter on the further dependent side of the posterior semicircular canal, and then you make patient sit. So what exactly happens like this? You see, when we make patient lie down, this is the otolith which is going towards the most dependent side. Wait for 1 minute, and once the vertigo or nystagmus goes, turn the head of the patient. So again, the otolith is moving towards the most dependent side, and again you turn the side as well as head, nose pointing downwards. So again, this changes the position of a posterior semicircular canal, and you can see the otolith is moving. And once the patient sits, it will go into the utricle. So now that this is how patient is treated. It is just a 5 minutes procedure in the clinic, and it can be treated. So similarly, for anterior canal, there is a different maneuver, superior canal, and for lateral horizontal canal, there is a different maneuver. So there is a supine roll test, which tells us whether horizontal semicircular canal are involved, and there is a barbecue roll maneuver, where you can treat this horizontal canal BPPV. And for a superior canal, there is a deep head hanging maneuver. So would you like me to show the video of each? Hello?
No, because time is up.
Yeah, okay. Thank you.
Thank you.
Thank you so much.
Thank you, Dr. Deepak, for excellent presentation. Because vertigo is a day-to-day complaint with which the patient come to our OPD, and very easily and simply explained by you. Thank you very much.
Thank you so much. Thank you.
Now, friends, now we move on to our next speaker, and we have a oncology topic. And to introduce the speaker, I request Dr. Sachin Patharkar to introduce Dr. Fahad Sheikh, sir.
Good morning, everyone.
Deepak, can you just stop screen sharing?
Good morning, everyone. Dr. Fahad Afzal Sheikh is a consultant medical oncologist and hemato-oncologist at Jaslok Hospital and Research Center. After specializing in internal medicine, Dr. Fahad underwent formal DNB training in medical oncology from Krishna Institute of Medical Sciences, Hyderabad. He is an ESMO, that is European Society for Medical Oncology certified oncologist. He received specialty certificate examination in medical oncology from Royal College of Physicians, United Kingdom. He was part of preceptorship on breast cancer in Singapore in 2019. He is well adept at medical management of patients with malignancies of breast, lung, colon, prostate, and ovary cancers. Beside prescribing conventional chemotherapy, he is well versed with targeted therapy, monoclonal antibodies, hormonal therapy, immunotherapy, and bone marrow transplant. He has been showing his keen interest in clinical research and has been a part of several clinical studies and randomized trials. He has also presented scientific posters and abstracts at various national and international conferences for which he won applause. Today, he will talk on basics to advance in lung cancer management. Thank you.
Hello. Yeah. Am I audible and are my slides visible?
Yes,
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 sir.
sir. Yes.
Yeah.
Yes.
Good. Thank you very much for the kind introduction. Good morning to everyone. I am Dr. Fahad Afzal, and at the outset, I would like to thank IMA for giving me this opportunity, and also to the wonderful audience who have spared their time and come in such large numbers on a Sunday morning. So without any further delay, let us begin with the presentation. I will be speaking on basics to advance in lung cancer management. Not able to change my slides. Yeah, sorry. So the next 15 to 20 minutes, I hope to give you a crisp and clear answers to these 5 important questions that would have surely crossed through many of your minds regarding lung cancer. Why is lung cancer so important to discuss? Where does the tumor exactly arise from anatomically? What are the risk factors and symptoms? How do we diagnose and stage lung cancer? And which treatment modality and agent to select for the treatment? This would be the structure of my presentation. We would begin with some recent facts and figures related to the lung cancer incidence. Then we'll brush up on our anatomy and then understand the risk factors and clinical features, going to investigation and staging workup, and finally the various treatment modalities and overview of management. We'll also touch on how to treat elderly patients with lung cancer and local palliative care. So in India, ICMR, that is the Indian Council of Medical Research, maintains registries for patients having cancer since 1985. The incidence, according to the NCRP, that is the National Cancer Registry Program, the incidence of cancer among males in the year 2020 was around 6.7 lakhs. And among females, it was even higher at 7.1 lakh. So going by this, it is predicted that during the lifetime, 1 out of every 9 Indian will develop cancer. It's a very unfortunate prediction, but this is what the numbers show. In the year 2020 alone, there were 8.5 lakh deaths because of cancer. Compare this to the number of deaths related to COVID-19 since the beginning of pandemic, it was 1.7. So cancer causes almost 5 times or more than 5 times the number of deaths. So the 5 most common cancers for females, the number 1 is, without any surprise, breast cancer, followed by cervical cancer, ovarian cancer, uterine cancer, and then lung cancer. Whereas in males, the number 1 most common cancer is lung cancer, followed by cancer of the oral cavity, prostate cancer, cancer of the stomach, and colon cancer. Overall, in both male and female combined, lung cancer is the 4th most cancer in India. It is responsible for 66,000 deaths every year. Unfortunately, more than half of patients diagnosed with lung cancer succumb to their disease within 1 year of diagnosis. And despite all the advancements in investigation and treatment, the 5-year overall survival still remains dismal at only 18%. That means after 5 years of diagnosis, only 18% of patients are alive. International data is also pretty much the same. Globocan, which is responsible for maintaining the International Cancer Registry under the purview of WHO and IARC, reported that there were 2.2 million cases, new cases of lung cancer in 2020, and it contributed to 11.44% of all the cancer diagnoses. Now, coming to the anatomy, the respiratory system begins from the nostrils going into the nasal cavity, while at the same time, the oral cavity, together they merge and form the pharynx, larynx, trachea, and then the lung. However, our organ of interest is the lungs. So the lower respiratory tract in particular begins from the trachea, dividing into the left and right main bronchus. The junction is called the carina. It subdivides to lobar bronchus, segmental bronchus, bronchiole, and finally ending into the tuft of gas-filled, air-filled sac called the alveoli. If you thought there is a very essential component in the lower respiratory tract, which is often overlooked, and that is the lymphatic system. And if you think that this slide was complex, then wait till I show you this slide. But fortunately, it is beyond the scope and objective of our presentation to know each and every lymph node and the nodal stations. So while discussing staging, we'll get to know why these lymph nodes are so important in taking treatment decisions. Coming to the risk factors. So if somebody asks me to list 3 risk factors for lung cancer, my answer would be 1, smoking, 2, smoking, and 3, smoking. So smoking is the primary risk factor for lung cancer, responsible for around 90% of all lung cancers. 1 pack per day for 40 years, that is 40 pack years, increases the risk of a person 20 times for developing lung cancer. And even if the person quits smoking, the risk remains and gradually falls over the next 15 years before it levels off and remains 2 times than those who have never smoked. It is not just the smokers, but also people who stay in close proximity to chronic smokers have 1.5-fold times increased risk of developing lung cancer. Besides this, the other risk factors are radiation exposure. This could be because of radiation therapy received for some other reason. It could be environmental toxins such as radon, asbestos, pollutants, wood dust, polyaromatic hydrocarbons, vinyl chloride, any history of underlying pulmonary fibrosis, any genetic predisposition which confers an increased risk of lung cancer in the entire family. However, on a brighter note, risk is reduced with certain dietary factors such as antioxidants, cruciferous vegetables, and phytoestrogens. So how does the patient present to us in the clinic? So the symptoms can be divided into general cancer symptoms such as loss of weight and appetite, and specific symptoms such as symptoms due to local tumor growth, symptoms due to invasion and obstruction, and symptoms secondary to distant metastasis. Coming to symptoms due to local tumor growth. So when the tumor is central, patient may present with intractable cough, not settled with common antitussives. There may be hemoptysis or blood in the sputum. There may be stridor. There may be dyspnea. If this tumor is peripheral, it may present with a pleuritic type of chest pain, which if present on the left side may even mimic a cardiac chest pain, and also dyspnea. Looking at the symptoms that are due to invasion or obstruction, so when the tumor spreads and grows in the regional lymph nodes, that causes enlargement of the lymph nodes, and these nodes can either invade or compress the adjacent structures. If it obstructs the trachea, it may lead to stridor. If it compresses the esophagus, the patient may present with dysphagia. Involvement of the laryngeal nerve may lead to hoarseness of voice. Involvement of phrenic nerve can lead to a medical emergency caused by paralysis of diaphragm. If it blocks the SVC, it can lead to SVC syndrome, which presents with facial swelling and puffiness, or it may even cause arrhythmias or pericardial effusion due to cardiac extension. Symptoms due to distant metastasis. If there are brain mets, patient may have seizure, altered sensorium, features of raised intracranial pressure. If there are bone mets, patient may present with low back pain if the vertebra is involved, or pathological fracture. Liver mets may present with right hypochondriac pain or jaundice. Adrenal mets would present with either adrenal insufficiency or hyperadrenalism. And especially in small cell lung cancer, they may present with various paraneoplastic syndromes such as hyponatremia or Cushing syndrome. So coming to the diagnosis, this simple algorithm tells us what would be the initial approach to a patient with suspected lung cancer. So imaging modality begins with a chest X-ray followed by a CT scan. If there is any evidence of lung tumor, we have to proceed with a PET scan. If the tumor in question is a peripheral tumor, then the options for getting the sample is a CT guided percutaneous trocar biopsy, or in some cases, there is an entity called radial endobronchoscopic ultrasound also, that is a type of bronchoscopy, and a more invasive form called VATS, which is video assisted thoracoscopy. If the tumor is central, then the best option is EBUS guided, that is endobronchoscopic ultrasonography guided biopsy. And it also gives us an advantage that we can stage the mediastinal lymph nodes in the same setting, because when we discuss staging, we'll get to know how important mediastinal lymph node involvement is in terms of treatment management. So it is not always that we need to biopsy the tumor in the lung, the primary tumor or the primary lung mass. The dictum in medical oncology is that the most accessible site has to be biopsy, which will lead to a highest yield. So I'll just quickly give you a case scenario. So if you have a case of suspected lung cancer, who on whole body PET scan has a left hilar mass, mediastinal lymph nodes, right supraclavicular lymph node, liver mass, and brain mets, I would want you to think for 5 seconds, what would be your preferred site for biopsy? So for those who have selected right supraclavicular lymph node, that is the absolutely right answer. It is the same pathology which is going over to the right supraclavicular lymph node. So we can diagnose, do molecular test, genetic test on the same right supraclavicular lymph node without entering the thorax. So that reiterates the importance of whole body FDG PET CT scan in lung cancer. This scan should be done before biopsy, and it would give us an idea about all the sites of involvement and help us decide which is the best site for biopsy. Once the biopsy is done, we get to know the histology. So the histopathology report lets us know whether there is malignancy or no malignancy. If there is a primary lung malignancy, whether it is small cell, non-small cell, or any other rare variants. In non-small, the most common type is adenocarcinoma, responsible for 40% of all non-small cell. The other common variety is squamous cell carcinoma, large cell carcinoma. So it is the pathologist's responsibility to see based on the histology and report whether it is a non-small cell or a small cell, and if it is non-small cell, whether it is adenocarcinoma, squamous, large cell, or any other rare variant such as carcinoid tumor. It is very important for us to know the subtype of non-small lung cancer before starting the treatment, because the treatment varies with each histological type. So often I am asked the question, what is the difference between non-small cell lung cancer and small cell lung cancer? So that's why I presented this table. So non-small cell lung cancer is the most common, responsible for 80% of all lung cancer. It originates in the epithelial cells of the lung. Common variants are adeno and squamous. It has less metastatic potential compared to small cell. Treatment modalities are usually surgery, chemotherapy, and radiation therapy. And the 5-year survival for early stage is improving. Almost 70% of patients can actually survive and lead beyond 5 years also. When you look at small cell lung cancer, this is slightly more rare compared to non-small cell, around 20% of patients. This originates from the neuroendocrine cells. Here, the classification is only 2 types, limited stage and extensive stage. There is no stage 1, stage 2, stage 3, and stage 4. This has rapid metastatic potential, and very often patients present with brain and liver mets at the time of presentation. The treatment modality is only chemotherapy and radiation therapy. There is no surgery, and the 5-year survival is extremely dismal. Even with the limited stage, the 5-year survival is only 20%, and with extensive stage, less than 1% of patients live beyond 5 years. So internationally, the staging system that we all follow is the AJCC system, which has T and M staging in it. T stands for tumor, N for node, M for metastasis. Based on the size and the extent of invasion, the tumor is given numbers such as T1, T2, T3, T4. Based on the lymph node involved, it was labeled N1, N2, N3. And if there is presence of any distant metastasis, we label it as M0 or M1. So this all looks too complicated, so I have tried to simplify in the form of pictures. So if the tumor is limited to the epithelium and not breaching the basement membrane and just limited to epithelium, then that is stage 0. Yes, there is also a stage 0. So here patient has carcinoma in situ. That means it is a non-invasive carcinoma. It also requires treatment, not chemotherapy, but only surgery. If it is stage 1A, the tumor is not more than 2 to 4. Just a second. Yeah, I'm sorry for the interruption. So if it is stage 1A, the tumor is less than 3 centimeters and the cancer has not spread to lymph nodes. If the tumor is 3 to 4 centimeters and it has not spread to any lymph nodes, then it is stage 1B. If the tumor is between 4 to 5 centimeters and it has not spread to any lymph nodes, it is stage 2A. If the tumor is between 5 to 7 centimeters and not spread to any regional lymph nodes, it is stage 2B. If the tumor is more than 7 centimeters, it becomes stage 3A. If the tumor is more than 5 centimeters and the cancer has spread to ipsilateral mediastinal lymph nodes, which includes the subcarinal lymph nodes, or if the tumor has grown into the outer lining of the nearby sites, it is stage 3B. If the tumor is more than 5 centimeters and has spread to mediastinal hilar lymph nodes and has grown into the lungs outer lining, it becomes stage 3C. If there is a tumor of any size and whether it has involved the regional lymph nodes or not, but it has gone from one lung to another to the opposite lung, it becomes stage 4A. And if there is any tumor of any size which may or may not have gone to the regional lymph nodes and has spread outside the chest, such as the liver or the adrenal gland or the brain or the bones, it becomes stage 4B. So as we can see, 57% patients present with metastasis, that is stage 4A, and 16% patients present with early stage, and somewhere in between 20% patients present with the locally advanced. As we can see, as the stage increases, the 5-year overall survival progressively declines. So coming to the treatment overview, in cancer care, it is not just the oncologist, though he is the captain of the ship, but it is not just the oncologist. There are different specialties and various healthcare professionals who work hand in hand and are responsible for the overall treatment of the patient. And hence we come with this term multidisciplinary team in oncology. This team includes physician assistants, oncology nurse, social workers, pharmacists, counselors, dietitians, and many other people. So the 5 main ways to treat non-small cell lung cancer is 1, surgery, 2, radiation therapy, 3, chemotherapy, 4, targeted therapy, and 5, immunotherapy. We'll be touching on each of these topics now. So first is surgery. So the goal of surgery in lung cancer is to completely remove the lung tumor and the nearby lymph nodes in the chest. This has to be removed with a surrounding border of healthy lung tissue, which is called negative margin. The various types of surgery for lung cancer is lobectomy, where an entire lobe of the lung is removed. There may be wedge resection, where the tumor is removed surrounded by a margin of healthy lung. It can be a segmentectomy, where just a bronchopulmonary segment is removed, or it can be removal of the entire lung, also called pneumonectomy. Look at radiation therapy. So in radiation therapy, we use high energy X-rays to destroy the cancer cells. There are various types of radiation therapy, such as external beam radiation therapy, brachytherapy, but the most common type is the external beam radiation therapy, where the rays come from out of the body. A typical RT regimen, a radiation therapy regimen, looks like this: 50 gray / 25 hash. So this actually means that 50 gray, that is the dose of the radiation, will be given over 25 fractions. That means 25 sittings. We don't use the word cycle. The word cycle is reserved for chemotherapy. So these 25 fractions are usually given from Monday to Friday, 5 days of the week. So this treatment, the example which I have given, would be for 5 weeks. It is important to note that radiation therapy cannot be used to treat widespread disease, because it is a local form of treatment like surgery. There are newer techniques such as IMRT, which is intensity modulated radiation therapy, and SBRT, which is stereotactic beam radiation therapy. The advantages of this is there is minimal exposure of the radiation to the healthy tissue, and more radiation is concentrated to the tumor. In some patients with stage 1 NSCLC who are either not willing for surgery or who are not fit, medically not fit for a thoracic surgery, radiation therapy may be an alternate to surgery. Next, coming to chemotherapy. So as we all know, chemotherapy is a systemic form of treatment. It is used to destroy cancer cells. It does not allow the cancer cells from growing, dividing, and making more cells. And there is enough data to show that chemotherapy improves the length and the quality of life for people with lung cancer of any stage. So a typical chemotherapy regimen consists of a specific number of cycles that is given over a set period of time. I've put an example, a doublet regime. That means there are 2 drugs of pemetrexed plus carboplatin, which is given every 3 weekly for 6 cycles. So since these medicines are given intravenously, it may be given through a regular peripheral IV line, but often we have to secure a specialized IV access, such as a chemo port or a PICC, which is a peripherally inserted central catheter line, for making sure that there is no extravasation or any local IV site reactions. Commonly, after giving these cytotoxic drugs, which are all myeloablative, they cause myelosuppression. It is followed by GCSF or filgrastim injections. A very common brand that we have is injection Nukai. So some of the commonly used chemotherapeutic agents are carboplatin or cisplatin, which are platinum derivatives, docetaxel or paclitaxel, which are taxanes. There may be gemcitabine and pemetrexed, which are antimetabolites, or even vinorelbine, which is a vinca alkaloid. Next, coming to targeted therapy. Now, cancer has specific genes and proteins which can be pharmacologically targeted. By doing this, we can block the growth and spread of cancer cells and limit the damage to healthy cells. So there are minimal side effects associated with targeted therapy, but not all tumors have the same target. And to find out the right target, we have to do certain high-end investigations to identify whether the gene that we are looking for is present or not. It can be protein, gene, or any other factors in the tumor. The most important targeted therapy for non-small cell lung cancer is EGFR inhibitors. So EGFR stands for epidermal growth factor receptor. So if patient has certain sensitizing mutations of EGFR, they will be right candidates to start EGFR inhibitors. These are oral tablets, and the only side effect associated with them is a rash that looks like acne and occasional diarrhea. Some of the EGFR inhibitors that we use and which is available in India are erlotinib, gefitinib, osimertinib, afatinib, and dacometinib. If you notice, all of them end with inib. Inib means inhibitors. When we have the word MAP, it means monoclonal antibodies. Besides EGFR, patient may also have mutations of ALK. If there are mutations of ALK, which is a protein that is responsible for cell growth, then we can offer them ALK inhibitors, such as alectinib, brigatinib, ceritinib, crizotinib, or lorlatinib. There are other such targets also, such as ROS1. The inhibitors are crizotinib again and entrectinib, which is been recently made available in India. There are drugs which target NTRK fusion. If this fusion is present in any solid tumor in the human body, and if they have not responded to any line of treatment, whether it is chemotherapy or any other target therapy, this medicine larotrectinib can be offered to them. In any solid tumor, it can be lung cancer, breast cancer, ovarian cancer. The next target is BRAF mutation, especially V600E. If patient has this mutation, which is commonly seen in melanoma, then the patient can be offered dabrafenib and tremetinib. They're all tongue twisters. And as recent as February 2021, they have discovered another target, the MEK exon 14 skipping mutation, found in 3% of non-small cell lung cancer. And the drugs that specifically inhibit this exon 14 mutation is capmatinib and tepotinib. Unfortunately, it is yet to be made available in India. Then there are RET fusion. mutations, which is responsible for 2% of our NSLCs. We have sulpercaptinib, which is another oral drug, and then anti-angiogenesis therapy, such as bevacizumab and ramucirumab, because tumor forms new blood vessels, which is called neovascularization. Anti-angiogenesis therapy act by inhibiting this neovascularization and deprives the tumor from getting its nutrition. Now comes to immunotherapy, which is a game changer. So immunotherapy has been designed to boost the body's natural defense to fight the cancer. The most important pathway on which it acts is the PD-1 pathway. This is an option for many patients with advanced non-small cell lung cancer that cannot be treated with targeted therapy. This immunotherapy may be given alone or in combination with chemotherapy. In order to understand, let us closely look at this diagram. So on your left, the T cell mediated activation has been inhibited because the PD-L1 present on the tumor cell has bound to PD-1 receptor, which is present on a T cell. Because of this binding, the T cell has become inhibited and hence it is not able to kill the tumor cells. On the right side, if you see, there is this orange triangle. These are anti-PD-1 agents, and the yellow semicircle is anti-PD-L1 agents. By giving these agents, we have avoided the binding of PD-1 with PD-L1. And because of this, the T cell has remained active and it can now kill the tumor cell. So as you can see, the agent itself does not kill the tumor cell, but it facilitates the body's own T cells to kill the tumor cells. Over the last 5-6 years, various immune checkpoint, these medicines are called immune checkpoint inhibitors. Various checkpoint inhibitors have been approved. Some of the names are in anti-PD-1, we have nivolumab and pembrolizumab. Anti-PD-L1 agents are atezolizumab, durvalumab, and avelumab. And there's another pathway which runs hand in hand with PD-1, that is the CTLA4 pathway. And the anti-CTLA4 agents that we have are ipilimumab and tremelimumab. Such was the influence of immune therapy in lung cancer that in 2018, the Nobel Prize for Medicine was awarded to James Allison and Tasuku Honjo, the two pioneers of research in checkpoint inhibitors, for their discovery of cancer therapy by inhibiting the negative immune regulation. So they help in releasing the brakes. So now coming to the treatment approach. So any patient with early non-small cell lung cancer, such as stage 1 or stage 2, should be treated with complete surgical resection whenever possible. For those patients where surgical resection is not possible, or those who refuse surgery, or those who are unfit for a major thoracic surgery, then radiation therapy is an option for them. For patients with locally advanced non-small cell lung cancer, that is stage 3, where there is involvement of the mediastinal lymph nodes also, the standard therapy is a combined modality approach using both chemotherapy and radiation therapy. This is called concurrent chemo-RT. Surgery may be done in some patients with stage 3 lung cancer also, provided the tumor is not bulky and the mediastinal lymph nodes are negative. Then comes to metastatic NSCLC, which is stage 4 lung cancer. Here the only option is systemic therapy. This systemic therapy may be chemotherapy, targeted therapy, or immunotherapy. It has been shown to prolong survival without sacrificing the quality of life. In some patients, for symptomatic relief and symptom palliation, radiation therapy and surgery may be given. For presence of any isolated metastasis, such as single metastatic lesion in the brain or in the adrenal, a resection can be attempted, and in lung cancer, it has been shown to improve the survival also. So the factors which affect our choice of treatment is the extent of disease, depending on number of sites involved and the symptoms of metastasis, the characterization of the tumor based on histology, whether it is non-squamous, squamous, adeno, small cell, and whether there is presence or absence of a driver mutation such as EGFR or ALK. If there is a mutation, we do not start chemotherapy. We prefer targeted therapy as the responses are much better without any side effects. And then we should also look at patient-specific issues such as age, comorbidities, and their own personal preferences regarding further treatment. So if we see this algorithm, any patient with advanced NSCLC, we have to first send the entire mutation panel. If any of the common mutations such as EGFR or ALK is present, we can go ahead and start them on oral therapy with respective targeted inhibitors. And if they develop resistance to that and relapse, we always have the option of chemotherapy for them. If the patient doesn't have any mutation to begin with, the only option for them is chemotherapy or immunotherapy, followed by some maintenance therapy to make sure that the disease is under control. For elderly patients who have poor performance status and who do not have any driver mutations, we try to avoid systemic chemotherapy because they might not be able to tolerate it. Quality of life remains the most important component than the prolonging the life. Best supportive care may also be given alone without starting any anti-cancer therapy. But if fortunately, if these patients have any driver mutation such as EGFR, ALK or ROS, then we can give specific inhibitors to these mutations. These, as I've already told, they have better toxicity profile and they are feasible even for elderly patients who have a very poor performance status, even the bedridden patients. Then there can be local palliative measures. If there is dyspnea due to a bulky central airway involvement, we can get a bronchoscopic removal of the tumor done to symptomatically relieve the patient. Sometimes bronchoscopic stenting may be done to maintain the airway patency, and in some cases brachytherapy, which is a form of local radiation therapy given from inside rather than out of the body. This can be given for recurrent or persistent disease in the airway. So my last slide concluding, there have been lots of technological advancements in the diagnosis of lung cancer. Early diagnosis improves outcome, and this is not just for lung cancer, this holds good for any cancer. Newer and newer targets are being discovered, and along with their inhibitors, immunotherapy appears very promising and is here to stay. And there have been many other developments in the management of NSCLC, and we can confidently say that lung cancer is treatable. And for my patients, I always tell them, you can survive. So thank you. This is my presentation. If there are any questions, I'll be happy to take them.
Thank you very much, Dr. Fahad. We have two questions in the question box. The first is by Dr. Kashyap Dakshini. What is the reason why lung cancer is detected so late at malignant stage, which explains the low 5-year survival?
So if there is a deep-seated lung tumor, the patient does not have any symptoms. Hello? Yeah, I'm audible, right?
Yes, yes.
Yeah. So if the patient has a deep-seated lung mass, there will be minimal cough, there won't be any hemoptysis, the patient won't have any breathlessness, and because of that, the disease would keep progressing, go on to involve the regional lymph nodes and even cause distant metastasis. This is the reason why peripheral tumors especially are detected very late. However, if there is a lesion which is much more in the center, closer towards the trachea, even a small lesion of say 1 to 2 centimeters may be enough to produce cough and symptoms of breathlessness, which would compel the patient to go to the family physician, where an X-ray would give a suspicion of a lung mass and can be diagnosed early. So since more and more tumors are in the periphery, the detection of, and since we do not have a lung cancer screening program like how we have in the UK, lung cancer is still not covered as a screening disease. Because of that, diseases are detected much late, and we have more stage 3 and 4 diseases compared to stage 1 and 2.
Okay. One more question is there. Dr. Rajan Patel. In adenocarcinoma, lung mass with pleural effusion is which stage? In these cases, is surgery possible?
So without any doubt, if the pleural effusion is a malignant pleural effusion, so we'll have to first do a pleural tapping, get a cytology done. If it is a malignant pleural effusion and not infective because of tuberculosis, then it becomes stage 4 disease. And as I've spoken in my presentation, there is no local therapy in stage 4 disease, no question of surgery or radiation. The only treatment is systemic chemotherapy or immunotherapy.
Thank you very much, Dr. Fahad. It was an excellent presentation on a very difficult topic as such. Malignancy is always a difficult topic for all of us, but you have made it very simple today.
Thank
Thanks
you
a
very
lot.
much.
Thanks a
Thank
lot.
you very much, sir. Thank you.
Friends, now we move on to the next topic, and that is the theme of the WHO Day today. Friends, the climate change is one of the most formidable developmental challenges faced by humanity today. As per the recent report of Lancet, climate change is the biggest global health threat of the 21st century. And to throw more light on this topic, we have a very eminent epidemiologist with us, and none other than Dr. Raman Gangakhedkar sir. I request Dr. Girish Rajadhyaksha sir to introduce this personality to the audience.
Thank you. Good morning, everybody. I welcome you all, and we are extremely fortunate to have a legendary personality to deliver his speech for this particular seminar. It is my pleasure and privilege to introduce Professor Dr. Raman Gangakhedkar. Actually, Dr. Gangakhedkar requires no introduction, but I would like to introduce him as an eminent clinician and an epidemiologist, and he is great in the field of medical research. He is Dr. C.G. Pandit, National Chair of ICMR. He has served as head scientist of the Epidemiology and Communicable Diseases Division of the Indian Council of Medical Research. He was the director in charge of the National AIDS Research Institute, or NARI, from Pune. He is a member of National Task Force on COVID-19. He is also a member of Lancet Commission of COVID-19. After doing his MBBS and DCH from Government Medical College, Aurangabad, he received his master's in public health at Johns Hopkins University, Baltimore. After completing his post-graduation, Dr. Gangakhedkar worked in several fields like National Institute of Nutrition, Hyderabad, National Institute of Immunohematology, Mumbai, and National Institute of Virology and Nutrition, and National AIDS Research Institute, Pune. He has been working in the field of HIV disease for over 3 decades. He is an expert in HIV medicine and associated infectious diseases. As head of ECD, he managed research and contributed to public health response in recent outbreaks of Nipah, Zika, and COVID-19. He was awarded Padma Shri, the fourth highest civilian award in India, for his service and research in HIV/AIDS. He has been member of many prestigious international committees on different facets of HIV disease, including those constituted by ACTG, WHO, UNICEF, UNFPA, and UNAIDS. Today, we are fortunate that he has accepted our invitation and he will speak on protecting health from climate change, which is the theme of WHO this year. So without wasting much time, I present before you Professor Dr. Raman Gangakhedkar. Sir, please.
Sir, can they, yeah. Thank you, sir, for the kind words of for introduction. I must admit that these days I tend to get lesser time, and the topic is as tough as one can imagine by the title. In fact, it actually surprised me that we are going to discuss it among healthcare practitioners, protecting health from climate change. Now climate change is what we are seeing as of now. There is global warming that's occurring across the world. Every from 1880 now we are 1.2 degrees centigrade warmer, and perhaps it's going to increase further in this particular century. The global sea level is also rising. The Arctic snow cover is melting at over 50,000 square kilometers every year, which means whatever the protection that we had from the nature perhaps is now becoming lesser, and we have become adversaries to the nature. And all of us know nature is far too powerful than human beings. If you look at global sea level that has been increasing from 1880, we know there was a small increase of zero point 0.8 inches until now, but it is expected that it will grow by 1 to 4 feet by 2100 AD. Now, which essentially means our interest would always be toward focus towards India. Look at the map of India. You will find that entire coastal line is going to face the challenge of handling this rising sea level, which is going to be a major task for all of us, especially on the western part of India. Now, one of the issues that we have to remember most often, we worry about the impact of climate change. When we think of impact of climate change, this tends to occur because of rising sea levels. This tends to occur because of extreme weather that you might see, the rising temperatures that may occur, and carbon dioxide emissions that are going to pose a challenge. Naturally, what will happen? They are going to impact in different domains of our life, whether it is severe weather, air pollution. The vector ecology is also likely to change, which we will see subsequently. Increasing allergens, water quality impact, water and food supplies, and environmental degradation. And what can they essentially cause? If you look at the diseases that could occur, you find that heat related illnesses such as death and cardiovascular failure perhaps are likely to occur more commonly. Forced migration and civil conflict may lead to development of mental health impacts as well, because people will be displaced because of these changes that are occurring. You will find malnutrition and diarrheal diseases are likely to become more commoner given the vagaries of nature. You would have different kinds of organisms which would perhaps affect our daily lives in different ways wherever these kinds of incidents tend to occur. And then there are certain infectious diseases which are likely to be more in certain parts of the world, depending on where the change occurred dramatically. And when it comes to pollution, all of us know that air pollution will lead to respiratory allergies, asthma and cardiovascular diseases again. And you would also find that there could be an immediate effect that might be seen in terms of injuries that may occur or fatalities that would be seen if these incidences tend to occur. Now, if you look at the number of heat waves that we are 1 minute, that perhaps we are likely to see among, we have seen among, if you look at number of heat wave exposures among more than 65 years old and try to look at the trend, you suddenly start realizing this is completely on an increase, and perhaps the people who belong to older generation will face lot of adversities, health related adversities due to this particular issue. Second thing which Second thing which we have to think about is who are the people who are likely to get affected because of these extreme effects. Now, it could be older adults and children. It could be people who tend to work outside their houses, those who are socially isolated and those who are economically advantaged, and those who already have chronic morbidity may find it difficult to cope up with the same physiologically. There would also be an impact on global work days that are lost by a sector due to heat, and that is apparent. It tends to differ by different sectors where I may be working, but largely where would the change occur? It would occur in agricultural industry far more compared to the industry that we tend to know different kinds of goods as such. If you look at what would be the impact on people, you'll find that the man days that will be lost by different countries, if you see the estimate that was there for 2018, could be worse because of these climate changes that occur. And look at the map of India. We stand out very prominently because we tend to face all kinds of adversities from different threats that tend to take place because of the climate change that we by and large see. Now, if you look at, if there are wildfires, because you tend to hear more perhaps from the Western world, but if you actually reflect upon, you will realize that wildfires have also started becoming common even in Indian setups. Nowadays, of recent, you find that wildfires are reported from different parts of the country as often as one could imagine, and that's something which is a worry that we would have, that there would be exposure to the wildfires per se, which may cause all kinds of issues at that juncture. If you look at the health impact of increased heat, normally our bodies are comfortable at 32 degrees centigrade as an ambient temperature. If you are living in a humid city, you would find that the effective cooling that tends to occur through sweating may not occur, and naturally you would have a greater impact in terms of this increased temperature on your own body. Now, what would happen there? This would perhaps lead to dehydration. This may also lead to development of heat cramps, and heat strokes would also be commoner in those circumstances. What is important is people have developed a scale called as relative atmospheric scale, and these scales actually tell you what kind of damage could it do. Most often when you have humidity and you look at the real temperature that you have, you find that humidity and temperature together perhaps would have an apparent temperature as a read, where you might see that anything between 32 to 40 degrees centigrade can cause heat cramps or heat exhaustion, and similar ways it keeps on adding. Once the temperature increases, you will find that the issues that are related to heat stroke would also come up dramatically in presence of humidity. The increased temperature can also cause, it impacts our food. So essentially what might happen, if you are living in a warm or humid climate, three different organisms, Salmonella, E. coli, and Campylobacter, are more likely to affect us largely. As it is, we must remember that foodborne illnesses, they tend to peak in summer, not summery, I'm sorry. And when you keep the food outside, then that's another issue that we have to remember. We may have to battle not only with the nature, but also the organisms that may grow mainly because of this particular impact. Now, what is the impact on floods, which is another natural calamity that arises because of climate change? You find that it may lead to immediate deaths. It may increase non-specifically the mortality. If you look at infectious diseases, you might see leptospira, hepatitis, diarrheal diseases, respiratory and vector-borne diseases occurring commonly. Exposure to toxic substances is also a possibility which you cannot rule out. There would be an impact on mental health, mainly because you pass through a severe stress at that juncture, and there is an increased demand on the health systems to access care and support for different issues that they face. Whatever health gains that we have made in certain diseases, because we have been able to ensure that among the infectious diseases, the decline in infectious diseases is to be seen. Perhaps this picture may differ now with the COVID-19 outbreak. Perhaps you might also find that infectious diseases, the so-called health transition model, is perhaps likely to be reversed, and we may still continue to go back to a state where infections will be a major issue that we will have to fight compared to non-communicable diseases. But if you look at what was happening, dengue was increasing. But if you look at diarrheal diseases, if you look at heat and cold exposure, that was also on a decline. Malaria was also on a decline. You look at protein energy malnutrition, that was also on a decline. Some of them may be developmental issues. They relate to the people's ability to earn money and also be able to have food security in place. And that's something which was being seen as a greater decline that was occurring. But at the same time, we realize that if you look at USA, one of those countries which is economically way ahead of rest of the world, now Vibrio was hardly ever seen in that particular area. But if you look at the changes that are occurring in sea, you realize sea surface salinity and temperature are impacting, and that has led to a better environment for Vibrio even to come in northeastern part of USA, and that's being increasingly seen. So there is a concern that when the sea surface would would change its salinity, mainly because of temperature changes that tend to occur, you will find that different infectious diseases profile is also likely to affect those countries as such, even if they are better in terms of their healthcare infrastructure or ability to handle different issues. And why is this happening? This is happening because if you look at the carbon intensity, the emissions that we tend to push into the environment, they have started increasing dramatically. If you look at our own lines, no, in terms of the highly populous nation, China, China has been always ahead of us. But if you look at the Indian line, you will realize that our numbers are also increasing dramatically. We are also adding to carbon intensity, but you have to keep that in the mind that we are still not a developed country. But the way we are rising, by the time we will be a developed country, perhaps our peaks would be far higher. And that's one of the main reasons why people tend to worry. Since you have a large population base, the likelihood that this contribution will also impact entire global picture is something which is a worry for the entire world. When it comes to pollution leading to changes in air quality and impact on health, it's very clear. Most of us know it can cause asthma, it can cause COPD, pneumonias, and even lead to premature mortality. And if you actually look at the winter season that sets in India, you suddenly start seeing headlines that majority of the large cities that we have or metropolitan cities that we have so poor quality of air that these kinds of diseases become extremely common. And it is now felt that the impact of premature mortality will be so high that even the lifespan may decline by close to about 5 years on account of pollution that we are facing as of now. When it comes to climate and waterborne diseases, all of us know that as the surface temperature tends to increase in the sea, you will find that even rivers would be impacted. And naturally, you will find that the farm is going to be exposed to certain, farming would be exposed to certain difficult challenges, and it is going to cause increase in terms of even waterborne illnesses, because eventually it is the same water which is either which we are likely to consume in the rural parts through the river, or if my ability to generate a potable water continues to remain limited because our water treatment facilities tend to be limited, then that may lead to major issues in terms of waterborne illnesses. Now, if you look at waterborne illnesses that tend to occur, one of the studies tended to show that when flooding occurred in Europe, what all diseases were actually observed. You see leptospira, you see emergence of West Nile virus. Now, please remember, this is Europe. No, you don't see these organisms as commonly in that part of the world. But if you look at cryptosporidium, that's also one organism that increases. E. coli, Campylobacter, Giardia lamblia, Synbis virus, norovirus, which is a notorious virus, that is also likely to be higher. And then you have anthrax, which has also been reported in the past as an impact of flooding that occurred in Europe. when we think in terms of earthquakes, are there different infection profile that we are likely to see? You would see that as hepatitis A and E, Salmonella enterica, and chickenpox had been reported after the occurrence of earthquake as a natural calamity. Now, what might eventually happen? You might find that there would be a return of diarrheal diseases, and perhaps the mortality may also increase. And between 2030 and 2050, the climate change is expected to cause an additional 48,000 deaths per year due to diarrhea. And that's a worrisome thing. What we have conquered in terms of health gains that could actually occur, perhaps is also going, we may go back and face similar circumstances to which we may have had thought that we have done our best in those circumstances. If you look at heavy rainfalls that tend to occur, sewage and backflow and contamination is something which is more likely to happen, which you also, since you stay in Bombay, all of us know the kind of problems that you face in the rainy season, which is also a reflection of the same issues. Increase in exposure to various viruses, bacteria, fungi, and also toxins can increase. It brings in cryptosporidia. It What is more worrisome is when the temperatures are raised of the water. What it does is it goes for bioaccumulation of methyl mercury, and if children before they are delivered in utero, if they are exposed to this methyl mercury, you might find that it would impact their cognition, and that's something which is also an additional cause of concern, which we may have to address later. When it comes to climate change and food security, this is no brainer. When the climate change tends to occur, you will find that it is going to impact on production of agricultural products. And naturally, we also know that the emissions of that would lead to increase in carbon dioxide that would happen there. You would find that all these together would not only in fact impact the animals which people tend to eat, including fishes. It would also perhaps impact us the way we eat, and it may cause supply chain disruptions. It may cause infected animals which would perhaps be consumed by people, and it would impact the food security because the people are naturally displaced because of the occurrence of such events. When it comes to climate change and mental health, one must remember mental health becomes an important issue because when people are displaced, they would be facing the stress and anxiety and depression that may come out of deaths that have occurred or separations that occur, or the issues related to their children not being able to thrive really well, and there would be a sense of loss. It would also affect our social relationships. There would be an increase in substance abuse, and all this is perhaps in response to the post-traumatic stress disorder that may occur. The violence is likely to increase in the community among those who have been displaced, and which is a common thing that we generally observe whenever displacements tend to occur. And there could be social instability because when you don't satisfy anybody's needs, in the social unrest is always likely to come, and there could be a decreased community cohesion, though you may still be within the same community as a refugee, but that community cohesion or being a social animal, that entire spirit would get a setback. That's another thing which we may have to handle. Worst case, what we had seen sometime in Punjab, farmers' suicides, mainly because of these issues of climate change and agricultural produce being impacted, either their quality was poor or the production quantity was also lower. That leads to farmers' suicide. Such dramatic changes could become more commoner if we don't address these issues as we move forwards. When it comes to vector-borne diseases, diseases are impacted in a different way. No, ticks, they are most often a common vector for some of the diseases. You find that they change their habitat. One of the best examples is leishmaniasis. you find that we were almost close to ensuring that visceral leishmaniasis as well as cutaneous leishmaniasis would be controlled. Cutaneous leishmaniasis, if you remember, was only occurring, it was not occurring as commonly in parts of India, but it was more in the Gulf countries that we were seeing. But now, as we are going towards elimination, we find cutaneous leishmaniasis is becoming more common, and that is mainly because the so-called mountainous colder regions are becoming warmer, and therefore the tick is also moving more on those mountains, and it continues to keep on spreading because it would like to have a warmer environment where it can thrive. Now, changing mosquito habitat, this is something which is also common, and naturally when mosquito habitat tends to change, you will find malaria, dengue, chikungunya, West Nile fever. In these are more likely to become commoner during these episodes per se. Now, it is also true that some of the new vector-borne diseases could also occur because of these natural calamities that would be there. Now, one of the things which we have also got to remember, if you look earlier into the history, you'll find that malaria was not occurring as often in colder temperatures. No, but today, if you actually look at even those mountains, people living on the mountains, they will also have malaria, mainly because the glaciers are melting at this juncture. The ambient temperature tends to increase, and that's going to be a major challenge subsequently. Though we also know malaria has come down even in India, but these pockets where we never expected malaria to be there, we always thought that it would be in some places near forest or in places where urbanization is taking very rapidly, and in such places which are tribal areas per se. But that picture is also changing. Now you find in the Himalayan range also malaria is increasing at this juncture. Now, if you look at what happens to dengue, you will find dengue is likely to come up as a important issue, and you will find that close to about 2 billion people are likely to be exposed to dengue by 2080. And you look at India's map that you see in the lower half, you will find we stand out as prominently as Brazil is, which is also a hot kind of, it has a hot ambience, temperate ambience, and also certain parts of sub-Saharan Africa where you are finding that dengue would increase just because of the issue of the vector being able to survive better in hot and humid environment. Why is this all happening? If you look at even that map little carefully, you will find that even those developed countries are also having outbreaks of dengue. Because basically one of the things that was there as a part of their life, they didn't have mosquitoes as common because their temperatures were low or colder, and their mosquito survival was very difficult. But you look at what is happening, nature finds its own way. Now what it is doing is, instead of aegypti, now the super spreader kind of a mosquito which is very aggressive is Aedes albopictus, and Aedes albopictus is increasing dramatically over last few decades, and that's something which is a worrisome picture, because we really will have to face the issues even in those developed countries where temperatures were also lower. Now, climate change affects human and animal interface. What do we exactly mean by that? Animals animals come closer to human habitat due to non-availability of food and water, deforestation that has taken, or also the floods that tend to occur. And you realize some of the best examples are Casnur forest disease, Nipah viral disease. They start emerging mainly because of the interface that tends to be there is almost becoming far more easier towards the exposure to zoonotic diseases. Which zoonotic diseases are associated with climate change and land use? You see Lassa fever, now, which was almost, which we haven't seen as much in our part. Leptospira, I don't need to tell to people living in Bombay, all that area around Parel, when the rain starts, you have leptospira, which comes up dramatically in that particular area. Lyme's disease is also likely to become more commoner. Zoonotic malaria, that tends to occur because of Plasmodium knowlesi, it is likely to come up. So far, we were assuming India is free of it, but there are reports that are occurring now reported from Andaman Nicobar that P. knowlesi has also been seen there in that part of the area of the country. Rift Valley fever, Ebola virus disease, and Nipah virus disease are some of the best examples where just because of the interface, even the zoonotic species jumped. And if you actually look at COVID disease also, no, you will suddenly realize that that has happened mainly because human beings have become aggressors, and they are also trying to consume different kinds of animals. One of them is bats. One really doesn't know why it is considered as so delicious an item, but I'm also told that this used to be a practice even in Kerala, northeast of our country, and perhaps that entire belt up above. They used to go for they also thought that there are certain medicinal properties to bats, and that's why bats consumption is as common. Now it could have a different vector, or a different reservoir from where they could have had gone in, but bat is one of the worst animals after mosquitoes, which is going to pose a major challenge to human beings. Now, how do you handle them? Now, one approach that CDC developed was brace. Now, they have 5 steps approach that has been generally accepted world over. One is you should be able to forecast the climatic impact, and you should be able to map the vulnerabilities that tend to be there within your own country. So you can predict where things could happen. And that's something which is very crucial, because you will have to advocate for health programs to ensure that we would have a good response that you could launch whenever such calamity strikes us. We need to project the disease burden that could occur. Now, if we know that on the western part of the country, now the sea levels are going to rise, what all health problems will occur? We should be able to project that so that we can act in time and try to safeguard our health interest per se. At the same time, assessing which public health implications could be very useful, could be an issue. You could evaluate impact and improve the quality of activities. Now, these 5 different approaches are considered to be important to build in resilience, because if you have thought it before, perhaps you will be able to prevent or at least mitigate the impact of this climate change that might happen. So, how to mitigate the impact of climate change on health? If you look at the measures that one may have to take, we need to initiate and enhance surveillance. Now, what do you do in enhanced surveillance? You look for specific diseases which were otherwise never seen in that area, but suddenly these cases have been seen in that particular area. You need to investigate why this has suddenly started. It could be an environmental factor that we may have to keep at the back of mind. When it comes to vector surveillance is actually a tool that can give you an early clue, because most of the diseases that are going to increase are VBDs, the vector-borne diseases. And if you have an integrated vector surveillance ongoing, the disease that could hit us is first predicted by the change that tends to occur in vectors that you find out, and that becomes an important issue for us to predict whether the subsequent diseases are going to hit us. Unfortunately, for vector surveillance, we have very few entomologists now in the country. Most of the people don't want to learn entomology because it's considered neither medical or non-medical kind of a situation. And people, though every state government, every central government tends to say we are willing to employ entomologists, but by and large those posts are not there. And therefore, this is one dying area where the need continues to be extremely high in terms of entomologists and vector surveillance. Now, we need to assess the regional vulnerabilities so that you map where could this happen and what all could we do. We need to strengthen the public health system to reduce the spread of these new vectors that tend to come, and as well as the disease which are a consequence of the change in vectors that is occurring because of climate change. We need to develop health preparedness to detect, train on required adaptive measures on trigger of natural disaster or climate. Now, what do? You look at temperature change that tends to occur. We need to have a plan where insecticides that we use for these vectors, which are the insecticides that I would use against different vectors. Vaccines and medicines, we actually need to plan appropriately at that juncture. In addition, what is important is we need to involve the community by creating awareness of these issues, develop group specific BCC to bring change in behavior, highlight case studies as to how this has happened, create a pool of community based opinion leaders so that they can ensure that the information is not only passed but people will adopt or change their practices. Provide them information on how to prevent the impact on health, such as food hygiene and potable water, plenty of fluids. What are the classical early warning signs which should lead you to seek medical consultations as such? At individual levels, all of us know, in order to ensure that the climate change doesn't hit us rapidly, we need to minimize use of vehicles. No, we need to ensure recycling tends to occur, and we have a reduced landfill in terms of storages. You look at saving of energy through variety of means, including even green energy that you can draw from solar panels, and composting of nutrients is vital because then you are going to reuse the same nutrients rather than looking at the deficiency that tends to arise because of it. Smaller measures like saving electricity by switching off when it is not in use, reduce use of plastics, reusable water bottles, and trying to go for forestation aggressively and plantations that you can have to make your household little greener in your own gardens or terraces would be an adequate and good response. In conclusion, climate change, actually, if you look at it, it is going to change the entire health scenario over a period of time. But the way it happens so slowly that one tends to forget that it could become a major public health priority a day. And if you look at the intervention measures, they are also going to impact so slowly that unless you begin early, you will never be able to stop them. So we need a stronger advocacy and action for making it into a public health issue. And we also need to recognize that people have to understand there is a high level of uncertainty in these issues because you can not so easily predict where and what is likely to happen, but we have to be prepared all through. This is an area which is very broad, and sometimes the interventions are generic and they tend to occur at macro level. So there is a fatigue that we have. There is a lack of clarity that tends to come in. But unless we start to work, we will never be able to refine what we should be doing. If you actually look at one of the best steps that government of India has done, you have NDMA as an organization. Most often we hear that NDMA or NDRF jawans have gone to try to help the population, but I have also seen them in action while I was in Delhi. They have almost developed SOPs as to how to counteract any kind of a natural disaster that tends to come. How will they be able to? And that building up of those scenarios is really nice, but they tend to work in isolation. The coordination between NDMA and the local health bodies has to improve over a period of time. Either NDMA should expand their role to prevent these events and mitigate the impact of the events. Currently, NDMA is more into mitigating impact, saving lives of people, or they should be able to coordinate with other agencies. We need to develop an integrated vector surveillance, especially that focuses on One Health. In One Health, we know that human health essentially depends not only on the issues that we tend to understand, but it also depends on animal health. It also depends on environmental health, and it also depends on the fisheries and the chicken that tends to exist, because these are going to impact us. And as a worst case scenario, which all of us know, by 2050, if we don't take right kind of steps in One Health, it is expected that antimicrobial resistance would be a major killer disease, and most of us will succumb to AMR over a period of time. Keeping that in mind, we have to make the climate change as a major public health issue. Within that climate change, we should be in ambit of One Health. We should also be looking at the health related impacts. And one of the major steps that we could take, while I was there in ICMR, we are planning currently in this budget, you must have heard that we are establishing National Institute for One Health in Nagpur, and we hope to see that that plays a real major role in defining what exactly we will have to do. Though the areas continue to remain hazy, but unless somebody starts working, clarity will never come. Thank you.
Thank you, sir. That was very beautiful and extensively covered all angles
Excellent,
of climate
excellent
changes.
informative talk.
Yes, thank you very much. You have enumerated and highlighted all types of direct as well as indirect effects of natural calamities on health of mankind. And you explained how it affects not only physical, but psychological and social outcomes of the human race. You have given an in-depth insight of the analysis of study of environment changes and how we continue to face communicable diseases. Sir, you have also given us a lot of solutions and very good tips of do's and don'ts of which human race has to follow. And to conclude, I would just ask that is the future of environmental study and epidemiology is microbes to microbes or still further?
Yeah, it has to be more. It's environment. No, I really don't know how many of you have been to Delhi during winter time, December to Jan. One just suffocates in Delhi. No, if you take the air, no, I used to stay in Asiad village, one of the prime areas in Delhi, very green. It is almost a forest-like area. But if you take the air within, you'll start feeling that the dust is going inside. It's that bad. No, it's beyond imagination. I think we need to take right kind of steps. We cannot just blame different governments or farmers for increasing the pollution. Unless we offer comprehensive solutions, nothing is going to happen. This is only becoming an annual issue that every year when winter will come, everybody starts discussing there is air pollution, it is going to kill us. But once the winter is gone, we all forget. That shouldn't happen.
Yes, there should be some more concrete steps taken. Thank you very much, sir. That was wonderful. Wonderful to have you with us. Thank you, sir.
Thank you.
Dr. Jitesh, can we take two questions?
Okay.
Yeah. So there are many questions. I'll just ask two of them. What are the three top things that we as doctors can do, according to you, to bring about the halt in climate changes?
I think one of the first top things that I would say is educate masses on when any such patient comes, when it comes to asthma. I'm giving a crude example, but it is time we also to start speaking about, why is this increasing? Why are you getting affected? Because every small change is going to help us in the longer run, to my mind. The second issue is all of us have to keep on advocating. See, we generally look at the outcomes. No? Once a patient develops a disease condition, we start chipping in. But it is time we have to have a balance. No? We can't be looking only at COPD and then not talk about how prevention also remains important. So we have to keep on talking, keep on communicating to people And what is also important is we need to conduct right kind of research. At the face of the research, the first thing that we will have to do is establish integrated surveillance, and doctors have to understand from that. Because I'll tell you a simple chota example. I won't be able to take second question because at 12:15 I have to join somewhere
Yes.
for an interview. But I will tell you only one thing. Casnur forest disease, we have a vaccine which was developed by ICMR. It tends to occur, it used to occur in Mysore district only. What was the requirement? The requirement was very simple, that people in the forest should only come and report that some monkeys are dead and lying there. And then once it is reported, we become vigilant and we try to understand how to stop that particular issue, vaccinate all those in the surrounding areas. And the reality is that coordination could occur only for 1 or 2 years. There were people who were posted even by the state government to help us out. But the truth is that today, Casnur forest disease, it is claimed that it is there in 5 states. It's not only one state now. Now, why am I telling this? We know and we forget very quickly. That's something which we have to avoid. We have to understand that integrated surveillance, which has to have a feed that comes from the doctor's side, is critical. I'll give you another example and stop probably. Now, while we were handling Nipah is a highly contagious virus. No, the spread could very easily occur from human to human if they touched any body fluid. No, that was as simple as that. We were completely taken aback when it occurred in Kerala, because earlier it was only reported from Bangladesh or the borders around Bangladesh, West Bengal states borders. What was worse was we could manage. We acted very quickly. We we acted in tandem because nothing much was known about Nipah at that point in time. We acted in tandem. Within 18 days we did a dramatic difference. But we realized the importance of this particular infection. We taught the doctors on how to detect, an unusual case that tends to occur in the community. Can you believe that only one case occurred after 1 year? Because now we knew in Kerala the bats have Nipah virus there. Only one case occurred, and it was only this professional skills of that doctor who was a resident who picked up. He said, perhaps this boy, no, has Nipah, and he straight away sent the sample for doing the test against Nipah. And the entire second year's outbreak was stopped with one case. It's just pure vigilance. Look for different syndromes that tend to occur, look for unexplained findings, and we'll make a difference together.
Thank you very much, sir. And it was really an amazing presentation. You got many comments in the chat box. You can just go through it when you get time.
I have to run. I'm sorry.
Yeah. Thank you very much. Thank you very much. It is always a feast to listen to you. Thank you.
Thank you, sir.
Friends, now we move on to our last speaker. Friends, with the increasing incidence of chronic renal failure leading to end-stage renal disease, the use of renal transplant as a therapy is increasing. And to talk on renal transplant, we have the last speaker, Dr. Prashant Rajput. I request Dr. Sarita Devi to introduce Dr. Prashant Rajput.
Good afternoon, friends. Dr. Prashant Rajput is a consultant nephrologist and transplant physician attached to Global Hospital and Transplant Center. He is also consultant nephrologist at Sir H.N. Reliance Foundation Hospital and Research Center, and associate consultant at Nanavati Hospital and Seven Hills Hospital. After graduating with MBBS, he pursued DNB in internal medicine in Dr. Babasaheb Ambedkar Memorial Central Railway Hospital, followed by DNB nephrology in Lilavati Hospital and Research Center, Mumbai. He has special acumen in treating patients suffering from chronic kidney diseases and acute renal failure. He is expert in hemodialysis and peritoneal dialysis, renal transplantation, and interventional procedures. He takes keen interest in research and has several publications in reputed medical journals to his credit. Today, he will speak on advances in kidney transplant. Thank you.
Um, Thank you very much, Dr. Sarita, for the kind introduction. Hope I'm able to do justice to this talk. I'll start with my talk. I'll also thank the IMA for giving me an opportunity to talk on advances in kidney transplantation. And we all know that there has been a significant advance in kidney transplantation after the Second World War. And this has been the major change in the last century. And it was the post-Second World War when we had a lot of patients with severe acute kidney injury following the war injuries, and they were able to they were able to treat a lot of these patients, and many lives could be saved. But they soon realized that chronic hemodialysis is an incomplete therapy, but because it provides only two aspects of kidney function, which is replaced by this procedure. One is maintaining the body fluid balance, and second being the removal of the uremic waste products. And therefore, transplantation research then started post the Second World War. And today, in my talk, I'm going to give you the outline of the about some history of the transplantation, some medical advances in terms of ABO incompatible transplant and paired kidney transplant, some advances as far as the organ allocation is concerned, advances in immunology and genetics, and how we use donor specific antibody and next gen sequencing for genetic causes of FSGS, some pharmaceuticals in transplantation, especially in context of newer drugs, some important developments in terms of organ preservation and transportation, and some surgical advances like laparoscopy and robotics in transplantation. As far as the history of transplantation is concerned, the research of transplantation and attempts of transplant started somewhere in the 1800s, the late 1800s. And it was not until 1954 that the team at Brigham's and Women's Hospital did the first transplant on 23rd of December. And this was between two identical twins. So they realized that there is an immunological barrier to transplantation, and they could successfully transplant two identical twins, the Ronald Herrick and the Richard Herrick. And this patient survived for about 8 years, and eventually the recipient died of a vehicular accident. This was the beginning of transplantation, and because of which the team led by Dr. Murray could do subsequently many transplants, and eventually in 1990 he was awarded a Nobel Prize for the same. It was not until the 1969 when they did a test which is called as a cross-match test. So this cross-match test was done by this man. His name is Paul Terasaki. He's an Japanese American, and along with him, Dr. Roman Patel. They published this paper, Roman Patel and Paul Terasaki, in New England Journal of Medicine, where they first described the significance of the cross-match test. And in this test, what they found was, of the 225 patients who were cross-match negative, only 8 developed hyperacute rejection, and those who were cross-match positive, 30 patients, out of the 30 patients, 24 patients eventually developed hyperacute rejection. And that was the time when they realized that there was something in these recipients which is causing the hyperacute rejection, and they realized that it was a preformed antibody which was causing it, and then it became mandatory to do a cross match test, and if there was a positive cross match, it became a contraindication to transplant. So this was the major benchmark test which even today is applicable as far as the transplant procedure is concerned, and this is one of the most significant discoveries as far as the transplant is concerned. The second most important discovery was of a drug called cyclosporin. This was first discovered from a fungi in Switzerland, and uh, it was Francisco Borel who was the first person to discover this drug. So why cyclosporin was important? Because it was a complete game changer in transplantation. The survival of transplant significantly improved after introduction of cyclosporin from 40% to about more than 85%. And it was introduced in our country in 1985, and subsequently till 2000 it was the primary drug which was used in transplantation, and this was later replaced by the crow brother of cyclosporin, which is tacrolimus. And today we have a triple drug immunosuppression in form of tacrolimus, cyclosporin, and steroids as a cornerstone of immunosuppression to prevention of rejection and transplants. As far as the medical advances are concerned, the most significant medical advances was for patients who did not have a blood group compatible donor. And this was the major barrier to transplantation. We had two options for these patients, and it was not until 2010 when we started exploring the use of paired kidney exchange and the ABO incompatible transplant. The problem with paired kidney exchange was the patients who or recipients who were O blood group and donors with AB blood group, and both of these group of patients would not get a transplant, and eventually very few of such transplants would have occurred. So this was a transplant which we did where the donor was O blood group who was donating to his wife, and we requested and there was another pair who was waiting for a transplant who was O blood group, and his wife was B. So we exchanged the kidneys. The O donated to O, the man donated to this patient, and eventually lady donated to the subsequent donor, and we could successfully do a transplant of this patients. And this is these are very few transplants which occur where you are able to do a recipient with O blood group. Then the only option remains is an ABO incompatible transplants, and it was not until 2014 when Professor Tanabe from the Tokyo Women's University visited global hospitals, and that was the time when we started our ABO incompatible transplant program, where we used rituximab as a drug to suppress the antibody, and we could use various techniques by which we could remove the antibody, and now about 20% of all our transplants are ABO incompatible. Of about 100 transplants we do each year, 20% are ABO incompatible transplants. The methods of removing these antibodies, we use plasma exchange. We have double filtration plasma exchange, and patients with high titers, we use uh, specific column of depleting a specific blood group, which is known as glycosorb, where only anti-A and anti-B antibodies are removed. And this now we have mastered this technique, but the problem with glycosorb remains that it is extremely costly. As far as the baseline anti-blood group antibodies are concerned, this was a paper we published in a few years ago. This was in 2015 in the Indian Journal of Transplantation, where we found that anti-blood group antibody titers and how did they respond to sensitization in kidney transplants. And what was very amazing in this study was we could demonstrate that Indians have a very low baseline anti-blood group antibody titers, and even 1 or 2 sessions of plasma exchange can be enough to circumvent the these antibodies, and a successful transplantation can happen without significantly increasing the cost of transplant. So this was a very important paper as far as the ABO incompatible transplants were concerned, as far as our country is concerned. The patients with high titers, patients with titers of more than 512, we started using this Swedish column, which is glycosol, which is now available in our country. It's about 3.5 lakhs to about 4 lakhs for each column, which specifically adsorbs the blood group antibody without removing the other antibodies. So this is a very, very interesting thing, and we could significantly reduce the antibody titers in patients with high titers. So we have been using these columns not only in kidney transplantation, but also in liver transplants, where we have done a significant amount or substantial amount of patients with liver transplants using these specific anti-blood group antibody columns. So we were able to do world's first ABO compatible transplants. This was a child who presented to us with Acute. He had a congenital kidney disease, mainly reflux, and since he was a child and he had an opportunity to grow, and we wanted to avoid the side effects of steroids. So we did this first ABO incompatible transplant, which was steroid free, and it is now reported as a first transplant in the world. Then we did a few interesting transplants, which was a transplant in an HIV positive woman. This was the world's second transplant, and this was published in the Indian Journal of Transplantation, as we did an ABO incompatible transplant in a patient who was immunodeficient positive, where your immunosuppression is challenged, and you have a high risk of developing rejections in this patient as well as infections in these patients. So modulating immunosuppression, specifically in patients who have an acquired immunodeficiency disease, was a challenge. And this was a second case which was reported in the Indian Journal of Transplantation by our group. The second most important was on the front of organ allocation. Now, those patients or those donors, especially the deceased donors who have terminal rise in creatinine, because of the change in the organ allocation policy, we are able to give 2 kidneys to a single patient. And this may be enough specifically when the recipients are older and they have they want to enjoy a good quality of life in spite of a dual kidney. And we could do a number of such transplants, about 6 transplants in the last 4 to 5 years, where we were those kidneys which were thought to be rejected were successfully implanted, and patients do extremely well when they get 2 kidneys instead of 1. And therefore organ allocation and allocating organs, especially with the extended criteria donors, have been beneficial if they're allocated to a single recipient. Organs which were positive for HCV and HIV positive donors, we have been doing transplantation from the deceased donors who were positive for HCV. And this was a patient who was HCV positive. We could successfully transplant this HCV positive kidney into an HCV negative patient, and we treated the patient with directly acting antiviral drugs, and this patient was cured of HCV. Uh, and the patient continues to do well about 3 years of transplantation. And this was also published in the Indian Journal of Transplantation as one of its case, first one in India. The other transplant which we did recently is an India's first HIV patient, donor HIV, donating to the daughter who's also HIV in June of 2020 when there was an extreme lockdown. So this is the first HIV to HIV transplant which was done also by a group, and this is in publication, and soon we will publish this first HIV to HIV transplant. As far as the technology is concerned in terms of immunology and immunogenetics, we have now started understanding the immunology of transplantation. And we know that the principal target is the MHC expressed on the donor cells. So this is the kidney. Once the kidney is transplanted, you have these antigen presenting cells, mainly the dendritic cells and macrophages, which enter the graft. They recognize the MHC, which is expressed on the endothelium of these kidneys. These antigen presenting cells will process the antigens. Similarly, how these cells process the antigens, the COVID antigens, to the T cells, and it is these T cells go back into the regional lymph nodes where they start proliferating, and they, after about 5 to 7 days, they mount an immune response to produce a rejection. So this is the exact mechanism how COVID also, because COVID is an virus which also is taken care by the T cells, and it is this T cells which produce an significant or very robust immune response after producing a clone of cells and producing a lot of cytokines, which causes cytokine storm in patients with COVID. And this is the same mechanism how the rejection process occurs. What are the causes of graft loss in our country? We have seen that most patients in our country will lose their graft because of production of antibodies, and this is very, very important. If you see the number of patients, about 64% of patients will develop an antibody post the transplant, and most important reason for that is non-adherence to therapy, and these antibodies are pathogenic and they cause the graft loss. So we started looking at this, and we started deciding, or we thought of deciding to monitor these antibodies, which are the donor specific antibody, before and after the transplant. So the donor specific antibody are very, very important because they will start rising immediately once the kidney is produced, once this kidney is implanted. And over a period of time, this antibodies would produce capillaritis. It would infect the glomeruli, producing glomerulitis. Eventually, after a very long time, you would see rise in creatinine and proteinuria. So whenever we monitor these patients who have DSA, and it has been seen that those patients who have these de novo DSA has a significantly less chances of survival, which is 59% to patients who do not have DSA, up to 96% at 10 years post kidney transplant. So it is important to diagnose the patients with de novo DSA. And therefore, each year we have this transplant conclave, which we did last in 2019, and where we discuss various modalities specifically for monitoring the graft in of these patients. And we have seen that this is very, very important. And if you are able to monitor the de novo DSA, you can significantly increase the survival of these patients. So this was the new venture which we started. It is the Advanced Transplant Diagnostics and Immunogenetics. This we started 1st of January in Mumbai, and this is the lab which takes care of all these antibodies and pre and post transplant, and we are able to monitor these antibodies to get an excellent graft outcome. One of the major barrier to transplantation is the antibodies which you produced against the HLA antigens, and now there is a drug which is available to break these antibodies. It's called IgG endopeptidase. It's called IDIS. Basically, what IDIS does is it is a cleaving enzyme. It's an endopeptidase. It cleaves the antibody into the FC and the FAB segment, where these antibodies then cause the CDC test to become negative. And when you do the transplant of the patients with antibodies, just with a single treatment of IDIS, you have significant reduction in these antibodies, and you're able to transplant these patients. This is an extremely costly therapy, not available in our country, but it is one of the most promising thing, which is especially in patients who are highly sensitized. And this is the landmark paper by Jordan in New England Journal of Medicine, where they could do an HLA incompatible transplants. As far as our group is concerned, we have for HLA incompatible transplants who are highly sensitized, we have this registry, which is known as the sorter registry. And here in this sorter registry, we use virtual cross matching, and we have this accessible mismatch program, which is only in the country, where we have now about 8 pairs have been transplanted in the last 2 years using this sorter registry, and they are from all 4 corners of the country. As far as the use of various techniques are concerned, we are able to remove kidneys as heavy as about 12 kilos. And this was a patient where, through the sorter registry, who was incompatible with his wife, could donate a kidney to another pair who had polycystic kidney disease. And this HLA incompatible transplant became a HLA compatible transplant using paired kidney exchange, and we could circumvent the uh, HLA incompatibility and ABO incompatibility of the other pair. As far as the other technique is concerned, which is extremely important, is the next gen sequencing. This is a very interesting case. You use next gen sequencing for detecting genetic mutations. And this was a very interesting case which we had a few years back. She was a 37-year-old ophthalmologist by profession. In October of 2012, she started having irregular menstrual cycles. On examination, she had a nephrotic range proteinuria of 7 grams with bland urinary sediments, and she had a normal kidney function. She got a native kidney biopsy done, and it showed this picture, which is the focal segmental glomerulosclerosis. You have a lot of wrinkling of and vacuolization and sclerosis of the segment of the glomeruli. This patient was treated on immunosuppression, and when she came to us for presentation, we could easily figure out what the disease was from the fingernails. So we could just, from clinical examination, we knew that this patient is suffering from a genetic disease and she does not require immunosuppression. And this was a nail patella syndrome. We did the genetic studies using the next gen sequencing, and what we could find that she had a positive LMX1B gene, which was detected in her blood, and almost 180 people in her family was detected eventually to have nail patella syndrome. And we could successfully transplant a nail patella syndrome father to the daughter, which is also one of the first case which is recently published last month in the Indian Journal of Nephrology. As far as the other use of genetic diseases, we have had this pair of patient who was having a peculiar mutation to the complement regulatory protein, and we could successfully do the transplant uh, and circumventing the ABO antibody, where we could easily transplant this patient because of certain genetic mutations between the mother and son. So we could use the kidney of the mother, who was the donor for this patient, to another patient who was diabetic with O blood group, and we could easily circumvent the ABO incompatibility, where the donor of the other patient, who was A blood group, could donate to a patient with having a genetic mutation to complement regulatory proteins. So we have various uses of these next gen sequencing studies, and it has helped tremendously as far as the transplant is concerned. Now we have simultaneous kidney liver transplant. We do this in patients who have end stage kidney disease. With end stage liver disease, we all know that liver does not have any form of replacement therapy like we do have in kidneys, and the only way for this is to undergo a simultaneous liver kidney transplant. And we could easily do a transplant with 2 separate donors, where the kidney was donated by the sister and the son donated a part of the liver, and this transplantation was done successfully without having any major issues as far as rejection or infection is concerned. As far as the immunosuppressive drugs are concerned, there is a major advance in this. There is a new drug known as iscalimab, which is a new compound. It's under phase 2 trials for kidney transplantation. It blocks the CD40 and CD40 ligand, which is the CD154 co-stimulatory pathway, and it has shown to prolong renal allograft survival in experimental models of transplantation. And there was a recent uh, article on this in the New York Times that this is set to replace the present immunosuppression by 2030. And this is also a drug, escalimab is used. It has shown excellent results in patients with Sjogren syndrome. And it will be a game changer. It is said to be a game changer in transplantation by 2030. As far as the kidney machine perfusion is concerned, this is the kidney machine perfusion. The main aim of this kidney machine perfusion is to minimize the reperfusion injury. It assesses the organ function based on the pressures within the kidney. You can deliver vectors for delivering therapies to improve the quality of organ. You can control the temperatures of organ if you have a hypothermic perfusion and a normothermic perfusion. These machines can keep the kidney in a viable shape for almost 24 to 48 hours, and it can enable the kidney to be transported. So this is a recent workshop which we conducted on the kidney perfusion machine at our hospital using the porcine kidney model. And soon we will be having these so that we can transport organs across cities, across the nation, and maybe across continents using these machines. As far as the surgical advances are concerned, our transplant program is a laparoscopic donor transplant, 100%. We also do robotic kidney transplantation at HN Hospital. The major advantage of robotic kidney transplant is especially in patients who are obese. The other methods, which as far as the surgery is concerned, is use of the indigo carmine to assess allograft function. This was a dual this is a kidney which we see which is implanted in the recipient, and you can see this black hypoperfusion. And when you have a hypoperfusion, that means there is a problem with the arterial flow. And when you do the anastomosis, you can see that the whole kidney becomes normal. So this is a very, very good technique to assess perfusion in kidney transplantation on the table where you have difficulty as far as the Doppler is concerned. Thank you very much for the patient listening. I'm not going to bore you with too many things. I try to make it practical and try to so that we all can help you as far as the complex transplants are concerned. And we all know that there is no transplant without a donor. There is no story, there is no hope, there is no transplant. And when there is an organ donor, life springs from the death, sorrow turns to hope, and the terrible loss becomes a gift. This is a very important quote from UNOS. So each one of us, especially the general practitioners, the family physicians, we need to make sure that each one of us signs an organ donor card so that anyone who needs an organ can get an organ, and then eventually can have many people get transplant. Thank you very much for the patient listening. And if there are any questions, we'll be very happy to answer them. And
Thank you very much, Dr. Prashant Rajput. There are two questions. I don't know the second one, but one question is there. What advice would you give to a patient who desperately needs a kidney transplant during the COVID-19 situation?
the most COVID-19, as we discussed, it is something which the most important thing is we have to vaccinate the patients. And if the patient is vaccinated and if they have a titer more than 4, they can immediately go for a transplant. We are doing regular transplants with COVID-19, even with less antibodies. The most important thing as far as COVID is concerned is the COVID appropriate behavior. If you are able to double mask yourself, if you're able to do social distancing and frequent hand washing. As far as our 50 patients which we have done during the start of this pandemic, or maybe 40, now we have about 40 patients. Only one patient has developed COVID. So it is important to follow the basics. And if you follow the basics, anyways, these patients are on immunosuppression. They don't have a very, very robust cytokine storm. And if you're able to take care of the infection early, you will actually have a good outcomes even if they have COVID. The most important is vaccination and COVID appropriate behavior. If you can do this, you'll have no problems as far as the organ transplantation is concerned.
There's another question. I don't know whether it's wrongly written down. There is written, can lung transplant be done in HIV positive patient? It could be kidney transplant.
Yeah, kidney transplants are regularly done in HIV positive patients. Now we have few first in the world. As I told you, we have first HIV to HIV transplant, HIV positive donor donating to HIV negative, HIV positive recipient, and we have HIV negative person donating to HIV, which is also an ABO incompatible transplant. So it is important that any and every patient with the the drugs which we have for treatment of HIV, and the better understanding what we have of HIV, we are able to do such complex transplant with ease. And now we have a good number of patients where we have done HIV positive transplant with HIV negative donors.
Thank you very much, Dr. Rajput. You have taken us right from the history to the recent advances in kidney transplantation. Thanks a lot for excellent presentation.
Thank you very much.
And now I proceed for the Thanksgiving program. I request Dr. Jagdish Kenny to propose the vote of thanks.
Yeah. Good afternoon to all. Hello. Hello.
Yeah.
Good afternoon to all. I would like to thank our speakers of today's webinar, Dr. Deepak Desai, Dr. Fahad Afzal, Professor Dr. Raman Gangakedekar, Dr. Prashant Rajput. I also thank our knowledgeable partners for the day, Intas Pharmaceuticals Limited, Sanofi Empowering Life, and Johnson & Johnson. Also thank Mr. Dipen Mehta and Mr. Piyush Kale from DigiShield, who have given us platform for this webinar and handled all the technical details at the same time. I also thank observer Dr. Sujatru Atar and all the delegates for the participating in the webinar to make it grand success. Thank you.
We always forget to thank Dr. Anil Awad, who is the main
Sorry.
program.
Thank you and all of panelists.
Thank you all, and we had a very nice attendance. We have crossed over 400 for this webinar.
Anil is beyond thanks.
Yeah.
He's a constant life member of this.
Thank you all. Thank you.
Okay. Bye-bye, everybody.
Thank you.
Bye-bye. Thank you all.
You should end the meeting.
Yeah. Thank you, everyone.